Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're talking to Dr. Timothy Hoff from Northeastern University about primary care on the brink towards a healthier tomorrow. Let's get started. Hello, Dr. Dan. It's good to see you.
Hello, Faisel. Happy New Year.
Happy New Year to you. And Dr. Hoff, so good to see you too.
Good to see you again.
There's a lot going on, especially in the world of primary care. One of the big frustrations that I have, we're getting into 2025, is that the common misconception that primary care is simple. Many people think that it's just like this basic checkups and treating minor illnesses. But, obviously we know that it's much more complex. I mean, can you shed some light that why still in 2025 people still consider it, to be so simple?
Yeah, it's $1 million question, right? We see with, you can see it even with what's happening with sort of retail clinics, right? And the investment in those and how I wrote an article about this in Harvard Business Review last year, basically, saying, hey, guess what? Primary care is not that easy to do. and these places, Walmart and CVS and Walgreens, that they all found that out. Part of it is rooted in the culture of our society and how we have been raised to think about our healthcare, right? We're still a specialty-driven system. We still run on a sick model of care. In other words, we wait until we get sick pretty much. I mean, it's gotten better with prevention, but it's nowhere near where other countries aspire to be or where we should be, right? So we culturally, I think, all of us, patients, providers, payers, we still view the complicated part of the system as the specialty care, as surgical care, and we still sort of lowball primary care. And even in areas like chronic disease management, right, that for many patients, it's not simple. It's actually quite complex. Patients have comorbidities and it's a longitudinal process to care for them adequately. But that's also, it's filtered that way into the payment system too, right? And so we have a payment system now that doesn't pay enough for primary care, doesn't financially value it enough. We know this. You've got the economic aspects of this, you got the societal aspects of this, and it all creates this set of beliefs that, hey, we don't need to pay much for good primary care. And, primary care, doing good primary care isn't that complicated. And, we can do 90% of it telehealth, or we don't have to pay providers that much to care for a patient longitudinally. So I think now that meaning system is so sort of ensconced in our system and in our society that, because even patients, right? Patients ask, do I really need a primary care doctor? Do I really need to have a relationship with the primary care system, or can I just wait until something happens and then somebody will flip a switch and I'll get a treatment or a prescription and I'll be fine? So we dug a real big hole for ourselves as a country, even with all that's happened over the past several years, with more recognition that this kind of medicine is not easy. We really still have a ways to go.
I was so excited with some of these big corporations, with all their resources, getting into primary care and with the reach and all of it, with increasing access, all that we were thrilled. And then to see them struggle, that was very hard for me as a family doctor. It makes me wonder if they were just corporate approach of like treating primary care as like a numbers game, rather than what you're talking about, like this relationship-based practice.
I wrote this article and it's called Why Retail Health Clinics Failed, right? But the lessons are really applicable to, and will be applicable to some of the other innovations, digital health, if we're not careful. A couple of the points that I made, one is, primary care is not a loss leader. You can't treat it, you've got to make it a central part of your business strategy, right? If you're going to do primary care, then you have to do primary care as a corporation or as a company, which means you have to invest in the infrastructure for it. So that's number one. And so a lot of these companies, they haven't wanted to do that because they've been willing to lose money on their primary care business because they thought it would bring benefits to their other business lines, whether it was pharmaceuticals or other retail products, right? I mean, that was like the Walmart vision. If you're going to do primary care, you got to do it and you got to invest in it. And I think we know that, right? From years and years of seeing, what it takes to do primary care that actually works and leads to better health outcomes. You got to financially support it. So that's number one. And number two, even though we had more of these primary care access points the past several years, right? The retail clinics, the minute clinics, the walk-in shops, doc in a boxes.
Standalone ERs?
Correct. Urgent care centers. And again, I wrote about this. They're all islands unto themselves. There's been no effort to really integrate at a local level, right? All the different primary care outlets. And, you have to put some of the blame on primary care doctors too, because they haven't wanted in their own offices to create collaborations with, some have, but, with the local urgent care center, or the local retail clinic or minute clinic, right? And of course, you need things like you need an integrated EHR to do that. You need to be able to have information flow back and forth. Without that consolidation and collaboration among the primary care players in a geographic area, all these places are somewhat doomed to underperform because they're only handling a piece of what patients need. And frankly, the business model for that stinks, because if all you're doing is low-level, low-paying, basic primary care delivery, you're not going to be able to break even mostly. I think there is a future, for these corporate primary care outlets, but the future is going to be trying to collaborate more with primary care physicians and primary care doctor offices. And then on the same token, primary care doctors are going to have to be willing to see some value in collaborating with those outlets that they sometimes view as competition.
I know a lot of the retailers are backing away, but that doesn't mean that people are backing away from investing in primary care. I mean, Optum, owned by United Healthcare and the largest physician group in the country, continues to buy up practices and work on expanding their reach. So it's not like, well, Walmart is getting out of this and Walgreens is getting out of this, and that means all the legacy players can just go back to doing what they've always done and everything's going to be okay for them in a business model. It's not going to work that way, is it?
You make a good point. Here's what I think. The sort of collapse of some of the retail health players in the primary care space this past year, which, by the way, 6 months before, everybody said this was a model that was just gonna explode and be so successful. I have articles I used in my classes from early 2024, and then I wrote the Harvard Business Review article in August of 2024, why retail health clinics failed. And it was like, woo! And I had to change half of my syllabus in my course. So that's how quickly things can change in the business realm, right? When a company encounters financial problems, and part of this, of course, is healthcare for a lot of these companies and corporations. It's gotten caught up in financial losses and strategic missteps, right? As some of these companies and players retrench, they've kind of jettisoned this version of primary care. I think it's going to come back. I don't think, like you said, Dr. Dan, I don't think this is going away, investment in primary care and corporate interest in trying to redesign primary care. But I do think it's going to have to look very different, and the assumptions are going to have to be very different. And I do think integration across the different primary care delivery points in a geographic area, integration is finally going to have to be recognized as something that is important and has to happen. And it has to supersede the competitive drive. The drive of like, hey, I'm a retail clinic. I don't really need to talk to the primary care offices in my area because I'm going to grab their patients in a different way, and I don't need, and I'm going to advertise to them, and I don't care what happens to them when they go back to their primary care doctor's office. I mean, that is going to be, to me, a failing view of how to move that business forward in the future. And we have the technology to integrate more now. There's no excuse for not having primary care physician offices, for example, in a local market, link up more closely and integrate more closely with the corporate outlets and the other sort of primary care players in that area.
It's interesting coming back into the academic medical center in a large integrated delivery system using the Epic EHR and having left the small group, the private groups. What's interesting, so the care everywhere where the Epics all tie up to each other, they give you the information, but it's not really as nice as what each organization gives the outside referring docs or referring into them. They give them a much more robust version of what it is. And if they can cut it on for the outside referring docs, there's no reason the health systems couldn't cut it on for each other. The medical information is being proprietary and not necessarily belonging to the individual patient.
Yeah, absolutely. That's a great point. I just know that the demand for primary care, right, is still huge. There's people, who can't get doctors. There's people who can't get timely access to any kinds of primary care in many areas of the country. There's a market need, and somebody is going to come up with an idea, a new idea, maybe, hopefully. It's hard to predict it right now because some of the best ideas we thought the last few years have now fallen flat, some of them.
With Trump coming back in again, what do you think that he'll prioritize?
Yeah, I'm a policy professor too, and I'm trained in policy. I've sort of given up trying to. Nothing about our political or policy climate goes by any of the theories I was taught as a policy student anymore, except maybe political and power theories, right? That those in power sort of create the policies they want. But I will say this: I don't think the Democrats have done primary care any favors either. There's been blame on both sides of the aisle. It's been ignored largely. The Affordable Care Act, in my mind, was the last big piece of legislation that did anything for primary care, in terms of, things it did, like even expanding Medicaid and things like that, ultimately benefited people getting better preventive care, things like that. But you could argue that governments increasingly don't have as many solutions to these big problems. And they also don't have any money anymore. And so, like I teach my students, certainly in America, the private sector is going to be the one that's going to have to invest. Because as John Dillinger said when they asked him why he robbed banks, he said that's where the money is. And I think that's, you can be normative and critique that and say, well, that's terrible. I can't believe that, government can't play a bigger role in funding or whatever else. But I'm a realist and a pragmatist. What do we have, almost $40 trillion deficit? To think that, for example, all this new money is going to drop from the trees for primary care, it's going to be way back in the line.
We all are pretty much like, okay, we got to improve access. We got to reduce the cost. With especially the new generation of the young doctors coming up, how do we sustain the primary care workforce itself? Especially now, we're getting to that point where, already the number one cause of bankruptcy is medical debt. We saw that horrible shooting happen with the healthcare executive, the insurance executive, and such a large number of us are burnt out.
I study a lot of physician workforce issues. I mean, the future. I've written about this. It's in my books. It's in my talks I give. It doesn't make people often feel great, especially primary care doctors. But the future only partially involves primary care doctors to reinvigorating primary care, because we're just not going to produce enough of them. It'll take, like I often say, even if we started now, medical schools opened up, 100 more slots per medical school to produce primary care doctors. First, you'd have to have the students want to pick primary care. So good luck with that, to fill the slots. But even if you could create those slots, you're talking about, 7 to 10 years before you even get the first wave of competent doctors coming out. We don't have that kind of time, and that's not going to happen anyway. Yes, you got Kaiser Permanente. They create their own little medical school for primary care doctors, and then but these little things that everybody's doing, they haven't amplified into a bigger effort to produce more primary care doctors, and partially that's because the people who earn the right going into medical school, many of them, don't see primary care as worthy of their choice as a doctor, right? And then even when they do, as you note, the younger physicians now, they see how difficult a job real good primary care is, and how does that align with their vision of work-life balance? How does that align with their vision of I want to work? Look, I want to be a doctor, but I only want to work 9 to 5. And sorry, but that's the way it is.
Yeah, the economics of primary care are very tough. How can we make it financially viable for both these independent practices and then you've got these massive systems. It's going to happen like what you said, like with the free market. I think so. I think that it's going to be a very painful transition.
As younger cohorts of primary care doctors replace older cohorts, right? Because you're going to have we're all in the generation of like, I'm not going to be doing this much longer myself. So, there's going to be an out-migration, a very large one, a different kind of primary care doctor replaced by a new kind of primary care doctor. The new kind of primary care doctor probably will end up having less power because of the preferences they will have for how they want to be primary care doctors. If you say I'm okay with being a salaried employee, then you lose power because you will put yourself at the mercy of the hospital system you work for, and they will tell you what kind of primary care you will practice. Right? We hear this with younger doctors all the time. They are anyone who works as an employee for a health system. You're a primary care doctor, but you don't have the kind of autonomy that someone who owns their own practice, has or, has practiced. And so as that power is lost collectively in the field of doctors, there'll be others to step in and fill that void. And that'll be big health systems, corporate players, and they are going to redefine what primary care means, and they will help also shape how the new primary care doctors will fit into the system.
I was in Italy just a couple of weeks ago with the family on a trip, and I was talking with an Italian doctor, and he said, "You guys complain all the time about not having enough doctors in America." He's like, "You have 1 million doctors," and I say, "Yeah, I know, but like literally we have less than 100,000 family doctors." And Dr. Dan, what's the number? It's like 2 out of 5 are nearing retirement or something like that.
Something like that, yeah.
Yeah, it seems like we have a lot. But when we meet the younger doctors, they still very much believe that the doctor-patient relationship is the cornerstone of family medicine, like to have effective primary care. And, I'm excited about all the AI, the ambient AI, and all the tools that are coming. How do we safeguard the human side of healthcare? Dr. Day, we were talking about another situation. Dr. Day, remember with your patient right before had a horrible diagnosis.
Well, and I've got to say that it worked well because a radiologist called me with a sort of devastating reading that was going to be talking about with this patient, and I was able to ask him. I said, "Can you suppress?" My big fear was we're going into the holiday. It's going to be released through the portal, and the patient's going to read this without somebody there. And this was like right at the end of the day on New Year's Eve. I said, Can you suppress this? And they were able to do that. And then I was able to call first thing in the morning on the 2nd. Now, there's not a book to look that up in, right? I mean, that seems like a pretty simple thing. But he and I are talking, and I'm thinking, I really don't want her to read this on her own. I don't know what she's doing for the holiday. And honestly, there's nothing to be done about it until the 2nd anyway, because all the other offices are closed. She's going to need some more tests and some more studies, and we were able to work together on that. But that was a human interaction, right? That was the radiologist calling and me saying, as the primary care doctor, what can we do? What can we do that would make this person's life a little bit better? And we were able to do that. So I've got to say, I know a lot of people don't like actually talking on the phone. They like texting or they like emails, but sometimes you actually do have to pick up the phone, and you can make a difference. And that can be with the patient, that can be with one of the other specialists. And I think that's one of the things that's happened over the years is the doctors don't have the doctor's dining room that they go to for lunch in the hospital, and they're not meeting and talking about patients. They're depending on these, and the electronic information is just not the same as when you're actually able to verbally talk about a patient with somebody else.
Yeah, I can tell you, my primary care goes through a very large, I won't say the name, but you could probably guess it, very large and renowned system in the Boston area. And it's impenetrable to get in touch with my primary care doctor. If I put a message in the portal, I will never get them to respond. It will always be there, a medical assistant who says, I talked to the doctor, or a nurse who says, I talked with a doctor. That's the problem. Okay. So if moving forward, more primary care doctors feel like it's okay to delegate important communications, like Dr. Dan said, maybe not that important, right? For me, I had a question I thought was important, and I kind of wanted to talk to the doctor directly through the portal. But their policy was, no, you leave the message. The runner, the runner picks up the message, the medical assistant or the nurse, the runner takes it to the doctor. They have 24 hours to get back to you. So, sometimes the time frame by which you hear something is completely random. So heaven forbid if you want a quick answer. Doesn't make this doctor bad. I actually like my doctor. I think she's great. When I'm in person with her, which is usually only once a year during my wellness check, I have a great conversation with her. But then, she's in a system that's making her work a certain way and shaping her behavior a certain way. And what I worry about is if these doctors don't build up a pool of experiences where they can see how much the relational aspects matter, that they won't know what's being missed.
There's a chapter in your book, and I forgot the exact wording. It's something about trying to train doctors and like trying to grow in infertile soil. And so what do you think what do we need to do about education for people who are interested in going into primary care as medical students and residents? What do they need to be focusing on learning to be effective, and where is the fertile soil to do this training?
Let's put aside a fact for a minute, the real, my own bias that I have very little faith in medical training in some ways, that because it's so focused on still creating specialists and creating, technicians. And now the focus is going to be on creating technicians who can use AI in their technical work, right? And not necessarily in their human work. But put that aside. Number one is, if you want more medical students to get excited about primary care, you have to show them a world of primary care work that doesn't oftentimes look dismal to them while they're in school, right? You hear research. There's plenty of research. There's plenty of research and anecdotes that show that there's lots of students who in their first and second year think about primary care, and they're idealistic. And then they start doing their rotations and they meet up with burned out primary care docs who say, oh, don't ever do this. Or they get put in a clinic in a hospital and they're doing episodic primary care with non-compliant and sick patients, and they go, whoa, this is I can't do continuity care. Is this what it's going to be like? So that one, thing one, right? Like people have said, you got to change where people are getting their experiences from while they're in medical school. The second big thing that I've become really a believer in is you're going to have to start integrating more training on business, more training on what it's like to actually be not just a physician, but a physician who's an employee. Like you're going to have to start to educate young medical students on what the real world of practice is going to be like if they choose to have a salaried job for a large system. Or if if they're in a setting where there's pressures to see a certain number of patients a day, right? When you have residency programs where primary care doctors are getting, 45 minutes to an hour to see a patient, that's not realistic, right? I understand that's done to get them more competent maybe in the clinical and relational aspects of care delivery, but then they go out into the real world and all of a sudden they have 10 or 15 minutes, right? And so we're not matching the exposure early on to what the real world's going to be like. And I think that's and I think some of these ideas we can fix them. But there has to be the stomach for it. And it's not just on medical schools. It's on residency programs, family medicine, right? I've talked about this. And it's on the older primary care physician cadre to say, look, we got to help shift the experiences these young people are getting so more want to go into primary care. And then once they're in it, they don't burn out from it.
It's much less common now than it was when I did my training. There were the community doctors would come in and they would spend like an afternoon a week or 2 afternoons a month as a community preceptor in the resident clinic, and they would tell us how they would handle things in their practice. And I still remember one of the old doctors teaching me how to take an ingrown toenail off. And the way I had been taught to do it, it was like you were going in to do bypass surgery, putting all on, and it was like an hour-long procedure. And he said, well, what are you doing? Here, you go in, you do the digital block like this, you do you flip the nail up with the clamps and you pull it off, and then you stop the bleeding. He said, it takes 5 minutes. Now, I can't say that I ever did one in 5 minutes, but I certainly after that, it never took me an hour to do one again. But I mean, that was very real world experience. And he hadn't read the surgical textbooks to tell me the exact way to do it, but he had done hundreds of those throughout his career. So he was very good at knowing how to do it and get through the day with it.
Look, if you're a young person, if you're not shown what things can be like, and you're also given negative experiences on what things might really be like, right? That's going to shape your decision making of what kind of career and occupation you choose, especially if that occupation is lower paying than the other ones that everyone's telling you you really should go into because, oh, look how hard it was to get into medical school. And are you going to settle for being a primary care doctor, right? Because there's that culture, right, where primary care is viewed as what one student told me a few years ago. It's a consolation prize. That's how it's viewed by many medical students. Even ones that want to do it, they get put into this culture where they have peers saying, "Oh, why would you do that? It's a tough job. It's kind of a miserable job. I went on rotation. I was in this clinic. But that's not really primary care, right? And that's not the good parts of it that they're not seeing. And then the digital part of it. I think for these young people, one of the ways to get them more interested in a primary care career is to start to bring more of the digital innovation into it. That there's so much digital innovation that we can start to think about applying to primary care delivery and even improving relational care. And I think the younger folks are going to love that. Because they're on their phones, 10 hours a day.
So what would you say then, in closing, to the next generation of healthcare leaders?
We talk about this a lot in my classes, and we talk about this concept of, we're very focused in the system and certainly in the primary care area on more access, more convenience, more timeliness, and we need all those things. I think what leaders have forgotten and providers, big systems and places that do primary care are forgetting is you can't just do that and lose the compassion and the empathy that the customer also wants, right? This is not about going into a Starbucks and waiting, online or waiting around with 15 people and having some gruff barista, sling your coffee at you and you're okay with it because that's what you expect there. Like you're not expecting empathy. The customer expects empathy in a healthcare and a primary care provider setting. And leaders need to keep remembering that. We can't get more access at the expense of lowered empathy, more callousness, distancing providers from patients. Like we just have to find a way to get better access, but also keep the relational component intact. And I think nobody knows how to make that happen right now. So I think we're going to have to experiment. We're going to have to try lots of things. But it starts with just, leaders sitting back and saying, what do patients want in this particular situation? I'll finish with like Dr. Dan's story about his patient and holding back the information. And right, that was an instance of extreme empathy, right? And we need to think about all the different touch points in the primary care system that patients need care for. What is the version of empathy in that situation that they want? And then we need to build the access so that it also incorporates that particular type of empathy. Maybe not every situation needs high empathy or high compassion, right? But other situations may need a lot of it. And so I just don't even think people are thinking about it because everybody's so frenetic with just trying to get patients through the door and out the door.
Dr. Hoff, thank you so much again for coming back on.
Thank you. It's a pleasure.
What are your thoughts on primary care on the brink towards a healthier tomorrow? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.